So fine, yes, please.
Hello, good morning. Thank you for the presentation. Especially in dialysis, we often have problems with patients that are they have high hemoglobin, 12, 13 plus, and they're iron depleted, severely iron depleted. What should we do? Because there are no guidelines here. I mean, it's a very unclear, foggy situation.
You already answered the question. It's unclear. So we do not exactly know what should be the status of iron replacement in patients who have got high hemoglobin. So the idea we know, we have studies which have showed that anything beyond 12.5 or 13 is detrimental to our dialysis patients. So I would suggest not to give any ESAs or iron therapy till the hemoglobin drops down, and then probably you can replete the iron stores rather than going for ESAs, which may take care of it.
Yeah, the problem is that they never drop. Thank you.
Thank you so much.
Thank you. So I think we'll hand over to the next group of chairpersons, Dr. D.S. Rana from Sir Gangaram, New Delhi, and Dr. Manjuri from Guwahati Medical College. Dr. Rana, please.
Thank you, Nisha. Next up is unlocking the potential of HIF PHI, novel approach for managing CKD anemia. And speaker is eminent nephrologist Dr. Dinesh Khullar from New Delhi, who is Director of Nephrology and Kidney Transplant Services at Max Hospital. Over to Dr. Dinesh Khullar.
Well, thank you very much. Good morning, everyone. Over the next few minutes, I'm going to talk about the concept of a novel therapy, that's the HIF PHI. We just heard from Tarun talking about the importance of iron, and we as nephrologists are well aware of the importance. But what we have also struggled equally is via the erythropoiesis stimulating agents. We were fortunate to have them a few decades back, but then we realized there were some shortcomings of those as well, and we are trying to evolve, trying to see if we can do something better for our patients. So these are my disclosures. I've been part of various trials on HIF PHIs. Well, we know the importance of anemia in the management of chronic kidney disease. We know both the importance of both iron metabolism, the functional iron deficiency, as well as the reduced production of erythropoietin. And we've also realized the importance of that molecule by the name hepcidin, which was not allowing erythropoietin to have its optimum action. And now we are trying to find ways to overcome this problem as well. So we've come a long way from what we were doing many years ago via blood transfusions to our patients with severe anemia in various stages of chronic kidney disease, to the availability of erythropoietin, and then finally now with the availability of HIF PHIs. It's quite an exciting world ahead. As far as the HIF PHIs is concerned, it all started when Semenza et al. Discovered the HIF transcription complex in 1995, and subsequently they were also awarded the Nobel Prize. And around the same time, we had the availability of roxadustat approved in a few countries, and then more recently in 2022, desidustat by an Indian company, Zydus. Well, before we proceed, just to recapitulate our knowledge about HIF PHIs, the HIF is a heterodimeric protein complex that responds to the changes in oxygen concentration, be it hypoxia or normoxemia. Well, they're clinically very exciting agents that stimulate endogenous EPO production while simultaneously taking care of the iron metabolism as well and its availability, its assimilation. So they exhibit potential for a more physiological approach when it comes to anemia management, and that's what I'm going to talk about. But again, recapitulation of the way they work as you can see in the normoxic conditions, the proryl hydroxylase domains, especially 2, hydrolyzes HIF alpha, which is then recognized by a VHL gene, and the ubiquitination takes place and finally undergoes proteasomal degradation, whereby HIF alpha now is not going to dimerize with HIF beta, and the erythropoietin sequence doesn't get started. However, on the other hand, if you have hypoxic condition or you have created a pseudo-hypoxic condition via HIF PHIs, whereby you replace the alpha ketoglutarate, and now you are not allowing the hydroxylation of HIF alpha to take place, which finally gets a chance to get translocated into the nucleus, and the gene transcription takes place. And of course, you can expect erythropoiesis. But the caution here and the worry here is that's not the only gene which gets stimulated. There are going to be whole other, and that's why we are fearing that something bad may come out of the HIF PHIs. Fortunately, not so far, even in the last so many years of its usage, both in the clinical trials and now the real-world evidence. But as we move on, there are multiple processes. It's not just erythropoiesis. There's angiogenesis. There's oncogenesis, two main concerns which we talk about when we talk about HIF PHIs. They have a role to play in fibrosis, inflammation, chemotaxis, oxygen sensing, while we heard about some good things when it comes to iron metabolism. But moving on, there are some pleiotropic effects as well. As you can see here, they've been shown to protect against the occurrence of acute kidney injury via scavenging reactive oxygen species, via their properties of anti-apoptosis, antioxidant properties, anti-inflammatory, and anti-ferroptosis properties. And it has been shown that they may have a role to play in mitigating the occurrence of AKI. On the other hand, there is a role in the diabetic kidney disease, potential role, I would say, again via anti-inflammatory properties and also via their regulation of energy metabolism, and they could actually reduce or slow down the rate of progression of diabetic kidney disease. Now, there are positive influences on the cardiovascular disease as well. As you can see here, via the anaerobic respiration increase, there could be a reduction in myocardial ischemic injury. There could be attenuation of hypertension, which was getting mediated via angiotensin II. Remission of atherosclerosis, because they have been shown to have positive influence on LDL as well as VLDL cholesterols. On the other hand, they have also been shown to offer neuroprotection. How? That's via angiogenesis. We were getting scared of the word angiogenesis, but then probably the focal cerebral ischemia gets protected under the influence of HIF PHIs. They have been shown to offer some kind of spinal cord injury protection as well, and some role in Parkinson's disease as well. But coming back to what we as nephrologists are interested in, and HIF PHIs, they work via not just a physiological improvement in the erythropoietin levels, but also helping in the iron metabolism, the assimilation. So what does the evidence say so far? Well, this is a meta-analysis of 26 randomized controlled trials with close to 25,000 participants, out of which about 60% were on dialysis. And as you can see here, HIF PHIs were found to be effective in correcting anemia in comparison with the ESAs, with a significant impact on iron metabolism. And none of these trials showed any significant safety signals with the use of the novel therapy as far as the cancers, the AVF thrombosis, the incidence of MACE is concerned. Well, moving forward and trying to compare the various HIF PHIs available so far, so this is a sort of comparison in 17 trials. As you can see, in about 17 trials, the indirect treatment comparisons suggest that all of them were comparable in terms of efficacy and cardiovascular safety for treatment of anemia of chronic kidney disease. However, daprodustat was associated with reduction in fatigue to a greater extent than the comparison with roxadustat. Now, we have heard about hepcidin, and we certainly want to know whether they have any meaningful impact on the levels of hepcidin. Well, desidustat was shown to have a positive impact on the hepcidin levels, at least in the non-dialysis dependent patient population on the left-hand panel. However, as you can see on the right-hand side, when it comes to the dialysis dependent population, the results, the difference was not statistically significant, although it was numerically. Now, moving one step further, whether they have any effect on post-transplant anemia, well, the answer is yes. Roxadustat was shown to have a positive influence on anemia in post-transplantation scenario. And the beauty was it had not caused any significant increase in the EPO levels. So what it means was they could increase hemoglobin levels effectively and safely by enhancing endogenous EPO production rather than relying on the abnormal and widely shifting EPO levles. So what is the current evidence of the pleiotropic effects? Well, they certainly have been shown to cause an improvement in the iron, glucose, lipid metabolism, some role in, as I'd shown in AKI protection, possible role in mitigating CKD progression, especially in diabetic kidney disease. The controversy really lies as far as whether they increase the risk of cancers, cardiovascular risk of retinopathy. I think only the further real-world evidence is going to give answer to that. But the clinical benefits are certainly quite significant, and that's in the form of oral route of administration. They increase or maintain hemoglobin levels effectively. They are physiological. They regulate hepcidin as well, help in the iron assimilation, absorption, and the inhibition of the HIF prolyl hydroxylate domains, be it 1, 2, or 3, is transient and is reversible, and they have not been found to cause any aggravation of hypertension, and you can actually avoid having abnormally high levels of erythropoietin in your patients, and also the requirement of IV iron also goes down. Well, this is the current status. They differ from each other in the way they act, and on whether they act on PHT 1, 2, or 3, and depending upon that, the frequency of administration also will vary, as well as the efficacy also may. Now, as we move on, and we are quite excited, as you can see, about the availability of this impressive class, we are also concerned about the various concerns, especially when it comes to thromboembolism, vascular calcification, heart failure, carcinoma, diabetic retinopathy, and polycystic kidney disease as well, because the cyst formation was found to be related to chloride-dependent fluid secretion into the cyst lumen. But what is more relevant is that AKG, the alpha-ketoglutarate, was found to have some very positive effects: the anti-aging, healthy lifespan extension, anti-osteoporotic, anti-inflammatory, etc. So if you were to take away alpha-ketoglutarate, you can expect that the uninterrupted activity of HIF alpha can actually not just give rise to erythropoiesis, but also to activation of plasminogen activator and TFI-PI, and finally it leads on to activation of platelets and monocytes and could result in thromboembolic events. So these are the potential concerns: the malignancy, retinopathy, liver function, dysfunction, hyperkalemia, hypertension, thromboembolic events, cyst growth, and seizures. But does the evidence so far really point in that direction? Well, the answer is no. As you can see in this comparative cardiac and adverse events of HIF PHIs when compared with placebo or with ESAs, as you can see on the extreme right-hand side, when compared with ESAs, they were found actually to be little better, while otherwise there was hardly any much concern about the cardiac or the kidney-related side effects. So as you can see here, the MACE outcome was comparable except for the vadadustat non-dialysis dependent patients. So what does the real world experience? We in India have been using it for the last 2 years now, and this is our own data from our hospital. As you can see, over 24 weeks in 64 patients, we could demonstrate hemoglobin going up from 8.9 to 10.1. But what is more striking is it happens more profoundly in the initial 12 weeks, then it sort of stabilizes, but still you can expect improvement till as long as 24 weeks. Also, there's a difference between whether the patients were EPO naive or they were already on EPO therapy. EPO naive showed better improvement, and the non-dialysis patient, dependent patients also showed better improvement. From other parts of the country, in this study by Ashwini, 84 patients, they also could demonstrate significant improvement in hemoglobin at each visit, which was 1 month apart, and over a period of 6 months, they could demonstrate a significant improvement. So with all these meta-analysis and the randomized controlled trials of them, the guidelines now say, and this coming from Asia Pacific Society of Nephrology, that you can consider HIF-PHIs as an alternative to ESA, especially after you have repleted the patient's iron stores, and this could be as a matter of convenience and also to overcome the hypo-responsiveness. And the UKK guidelines also, they have put the treatment of anemia as class 1B, as you can see here, guideline 4.1, whereby it is recommended that treatment with HIF-PHIs should be considered, of course, after iron repletion to patients with CKD stages 3 to 5 with symptomatic anemia who are likely to benefit in terms of quality of life and physical function, and certainly to avoid blood transfusions. So the ERBP guidelines also, they talk about considering the use of HIF-PHIs, and also they've cautioned as to where not to use. So for the sake of repetition, I'm skipping this, and these are the potential advantages according to ERBP, most of them except for hemodialysis, where it does not offer any convenience or needle overcoming the needle phobia. Well, you can see in most of the other areas, it scores over the existing therapies. Well, to summarize, HIF-PHIs offer a more physiological approach to CKD anemia management with an additional role of enhancing iron absorption. The oral route of administration is a big advantage, especially for non-dialysis dependent patients. It is cost effective and potentially offering an improved quality of life, and hopefully survival of these patients. Have other clinically significant pleiotropic effects, especially reduction in atherosclerosis, cardioprotection, protection, and neuroprotection. And so far, the theoretical concerns like malignancies, proliferative diabetic retinopathy have not been shown to be of much concern. Thank you very much.
Thank you, Dr. Dinesh, for the wonderful presentation. May I ask you, how will you monitor the dose of desidustat, or how did you monitor the dose in your study?
Well, we typically start with 100 milligrams on alternate days. It has effect on PhD domain, all three domains, 1, 2, and 3. So it has a long half-life. So the administration has to be on alternate days. And then you titrate at the end of 1 month. You go back to decide as to whether to continue the same dose or increase to a maximum of 150 milligrams on alternate days, or reduce to the lowest dose of 50 milligrams. And of course, the targets remain the same. You have to keep the levels of hemoglobin between 10 and 12.
Thank you. I think we can take one question from the house.
So you will say that it's mandatory that all patients who are going to be put on oxemia or reductostat should have an eye checkup? All diabetics especially?
Yes, I think
they must before putting them.
It's very important. There are concerns with retinopathy, with malignancies. I think people, for the paucity of time, I didn't go into the details of what should be the policy. People with the pre-existing malignancies or historical malignancies should at least be excluded for the time being. People with severe retinopathies, people with severe peripheral vascular disease, I think we should tread the path very, very cautiously till you have the final safety data. I think whatever has been shown so far is more via clinical trials, which we all know are very, very strict. But I think we should rely more and more on the real-world evidence. But then, thankfully, there is not much concern, at least of the past few years, not just with desidustat, but also Roxa and the others, which are, they may not have received FDA approval except for desidustat for the dialysis population, while others are available in Europe, Japan, China, etc.
Thank you. So we hand over the mic to the moderator of the next session, to Dr. Sampath Kumar.